Hi, everyone. Good afternoon, depending on where you're joining from. I'm so excited to be having a conversation today with Judy Ribner, who is a home birth midwife based in the Five Towns. And I'm going to invite Judy to join. So let's just give it a second. Okay, hold on. There we go. We got so many good questions, and I have a lot of questions prepared, so this is going to be a good one. So let me just wait for Judy. Hello.
Hi, Lauren. How are you?
Good. I see your computer.
I'm switching
On
it
your
right
face.
now. You're much more tech savvy than I am, that for sure, by the way.
I don't know about that, but we're learning. I feel like every time I do an Instagram live also, like, it's a little, they change it. I don't know. They like change the format.
Got
So
it. Okay.
they're always throwing things at us. So thank you so much for taking your
Sure.
valuable time to have this conversation today.
I'm so humbled to be here, by the way. Like, I feel so touched that you invited me. I mean it. And um, what I appreciate about this, what you're doing is so often when people are offered the menu of options for their birth, it's all decisions within the context of a hospital system. Do you want an epidural? Do you not want an epidural, right?
Right.
Do you want to be medically induced electively? Do you not want to be medically induced? But you're coming with a totally new approach. You're starting from the bottom up and you're saying choice. Choice can start with birth setting. So you're really offering people the full menu of birth options within an industrialized country's maternity care system. So if I can be the voice to that other side, I'm gonna step into that role in a very humble way. And it's courageous because I'm gonna tell you why it's so courageous to talk about home birth. You know, I live in the home birth world. Everyone I know around me gives birth at home, right? All my clients give birth at home. My sisters all give birth at home. My friends give birth at home. I give birth at home, right? Everyone I know gives birth at home virtually, right? But the minute I pull myself out of that, in the United States, less than 2% of birthers give birth at home. This is not the Netherlands, where the home birth rates are about 20%, and that you could have people who are obstetricians who give birth at home. We're in a society that choosing home birth is like,
it's extremely countercultural.
Right.
Yeah.
It's like, right. It's like, right.
So not the norm.
Right. So this discussion is important because there's a lot of misinformation surrounding home birth or just lack of information surrounding home birth. And you and I both know that, right? Because like we have pediatricians who ask, like, was the baby weighed at the birth? Like, was there any evaluation for the newborn at the birth, right? We've heard comments like, oh, if you do a home birth, can you have blood work? So I would love to be able to share what home birth really is. So you take the reins, Lauren. You're courageous, and I admire you for it. So
thank you.
Yeah,
well, I appreciate that, and I'm so glad you're here. When a few months ago, well, I guess it was like 6 months ago at this point, back in November when you had the event. So for anyone listening, Judy and I are both based in Long Island in like the Five Towns Far Rockaway community, and there was a really nice birth networking event which had huge turnout. And one thing that I took away was, Judy, just like your passion and like your clarity on home birth, and not just from like a passion standpoint, but also from like a scientific factual standpoint. And to your point about people having misinformation or lack of information around home birth, I do find from my own experience and just from hearing conversations around home birth from people that are not like the people in your network, from people that are, birthing in a hospital, there's a lot of like, well, home birth, like, how can that be safe? Why would anyone do that? That's crazy. That is, it's bizarre. And I think that you have a lot of answers to those questions that are based on facts and science. So that's what I'm really excited to have here today. Like, for anyone listening, if you have ever just been curious about home birth, like, what's the story? Or maybe you're considering home birth for yourself, and you don't feel like you have any outlets to discuss it with people because you're feeling like you might get judged. So hopefully this could be like a safe space for anyone, no matter whether you're choosing to birth in a hospital, unsure, just curious. And that's how we're going to approach it today. So I have lots and lots of questions for Judy. I don't know how far we'll get, but let's see. So Judy,
I'm all yours, Lauren.
Do you mind just sharing, before we get into like the nitty gritty, do you mind just sharing a little bit about yourself and you know, how you got into this type of work as a home birth midwife.
Sure. The day I was born as a midwife was probably the day I was born on this earth at 7.5 pounds. My mother birthed me with Lamaze in a hospital setting, but it was a conscious choice to birth me in that way. And my father was exquisitely supportive of that. So there's cellular memory in a newborn's experience of what happens to them at a birth. And I think that that birth may have really impacted the way I view my own body, women's bodies, and the natural process of childbirth. And as my professional education evolved and I witnessed birth in a hospital setting, in New York, I was trained exclusively in New York. I've seen birth in other parts of the world, but my professional training was in New York. I was opened up to the reality that more than a third of people in New York have major surgery to have a baby. I was opened up to the reality that it is normal to be medically induced to have your child. I was opened up to the reality that birth has become wrapped up within the medical system and with medical intervention. And there is time and place for that, but the rates at which it was happening were quite curious and alarming to me. And then from there, things just fell into place, and there's nowhere else I would want to be other than where I am right now. So that's why I am where I am.
Can you tell us, like, just briefly, the steps in the training and certification process for someone like you, so who's a CNM, a certified nurse midwife? So I mean, that's a big misunderstanding that people have around what actually a midwife, what their training is and what their background is, scope of practice. So can you tell us a little bit about that?
Sure. In the United States, the term midwife is ambiguous because there are three recognized pathways to becoming a midwife. And within New York, there are two, CM and CNMs. Yeah. A certified nurse midwife is someone who's a nurse, a registered nurse, and has a bachelor's degree and then a master's level degree in midwifery or nursing and sat for the boards to become a midwife. A CM is also a graduate level clinician. The only difference between a CM and CNM is that a CM is not a nurse, but in terms of their scope of practice, they can both care for women across the lifespan in the state of New York. They can care for a 12-year-old girl and a 75-year-old woman. They can care for women during pregnancy, birth, like deliver the baby, receive the baby, postpartum, do a newborn evaluation, provide contraception, pap smears, annual exams. CMs and CNMs in New York can prescribe medication. They are not required. They have like a prescription pad, you know, just like a physician would have. They are not required to have any formal collaborative relationship with a physician, which means they're an autonomous healthcare provider with their own independent practice. They can be the way a physician can have an autonomous independent practice. And much like the way an internist who has a patient who has a cardiology issue will refer to a cardiologist because it's not an internal medicine doctor's specialty. Similarly, a midwife who has a client who develops a complication will refer appropriately to a specialist like an obstetrician or maternal fetal medicine specialist or a cardiologist, whoever the specialist that's appropriate. So midwives diagnose medical conditions or healthcare problems. They treat those problems. They can order lab work. They can order ultrasounds. They can follow up on the care, evaluate the care plan. And they also, what I love is that they don't view natural life processes like pregnancy, birth, menopause, normal female life cycle events. They don't view them as medical conditions. They view them as normal life cycle events, and they try to keep them that way. So we're going to get more into that discussion. I know you're going to ask me something about that. So
so you're getting into my next question, which is like the philosophy, like, and the philosophy between, you know, a midwife and let's say a more traditional, you know, medical, like obstetrician, for example.
Really good question.
So you just started, I guess, hinting at that, which is you view these life cycle events as normal. Can you just expand a little bit on more, like, what does that actually mean? Like, or maybe you can give an example, what might that look like for someone who's pregnant or giving birth, because that's probably most of the people who are watching. I don't know, maybe I know my grandmother follows me on Instagram, but most people on here probably not, and then like menopause
I
stage
love
of
that,
life.
Lauren.
So can you maybe give an
Sure.
example as it relates to like pregnancy and birth, how like something that would come up, how a midwife would approach it, and then versus like how an OB might approach the same thing?
Sure, sure. That's such a good question. So a midwife can really be a person's primary care provider, and a woman can get care. Most women can get care with a midwife from start to finish during their reproductive years, after their reproductive years. They can do all their women's health care needs with a midwife and not need to walk into a physician's office. So I like people to know that it's a one-stop shop for most women's needs. It can be a one-stop shop, just so that people know
So a
that.
midwife is not just like a woman that, you know, like a woman that you like find on the street and that just like has her handbag and her cell phone. Like she's a full
Right.
medical provider. Okay. So
She's a full healthcare provider, right? Like she can, she can call into the pharmacy to get a
People
person
really don't
medication.
realize that.
Right. She
They
can
really
do she can do a pap smear and send it off to a lab. She can do blood work and interpret those blood results. If a person wanted to not need to go to a medical doctor and have care with a midwife, most people can make that choice, and it would be within the scope of practice of a midwife.
Okay.
There are distinct differences though between a midwife and a physician, and it's multi-layered. It's not only the way they practice clinically, it's also a philosophy of care. And you were touching on that, and let's go deep into that. So the midwifery perspective is that a pregnant person is not diseased. They're a healthy person completing a physiologic process that for the majority of people will be healthy and normal throughout the pregnancy, throughout the birth process, and postpartum. And in a minority of people, there will be complications, and that those people with complications are identified because all women are screened during pregnancy routinely. They get prenatal care. They have screening tests performed. And the minority of people who develop a complication are referred for the appropriate care that they require. But for the vast majority of women, they're healthy, pregnant, and that there's no reason or indication to intervene during the labor process or during the birth process unless there's a specific clinical indication to do so and that there's trouble there. But for the vast majority of people, letting the body do its process at the rate and in the way the body and baby want to do it, that will yield the best outcome. That's the midwifery approach. They believe in what's called expectant management. Expectant management means let the process unfold, and if there's trouble, we'll step in and get involved. Active management is what the medical model of care endorses. They say a person's in labor, let's intervene, because by intervening, it will make it better. Pregnancy is a high-risk condition for everybody. For some people, it's even higher risk because they have complications. But anybody pregnant benefits from some level of intervention. And by our controlling it with drugs and other medicalizations or an induction, we will yield better outcomes. So it's a very different philosophical perspective to say that pregnancy and birth are normal life cycle events. And of course, coming from that perspective, home birth makes sense, right? Why would we routinely hospitalize every last pregnant person? We reserve hospitals. We have a philosophy that if you reserve hospitals for people with high risk conditions, that's the best model of care, right? But that a low risk person is a healthy person, so they can birth at home with a qualified professional who's prepared for an emergency. And we're going to go more in depth about home birth. But just taking a step back, I'll tell you exactly how that would translate. That means that if a woman is in labor and her labor is progressing normally, a midwife who's practicing by midwifery model would not break her water, would not give her Pitocin to move things along. A good midwife who's truly practicing midwifery will step back and let that process unfold. She will encourage that mother to birth in a position that her body guides her toward, because she trusts birth as a self-sufficient process. The medical model of care is more, oh, you're in labor, let's get this baby out, let's get Pitocin going, or let's break your water, let's get things moving, or let's monitor this labor continuously, because We look at birth as a high-risk medical event, and therefore we want to intervene. So the medical and midwifery model of care is not only different clinically, there's another fundamental difference. Midwifery emphasizes shared decision-making, which means we're in an equal partnership. The midwife and client make decisions together. It's not an authoritarian model where I tell the person what to do. It's like I honor that this mother knows her body, has a value system and preferences and experiences influencing her choices. I share with her information, and then together I can make a recommendation, but ultimately midwifery respects individualizing care, which means making modifications based on what the person wants, and involving the woman in her own care. Midwifery was actually a feminist movement in the United States. So in the 1970s, the women who were feminists and were waking up to 1 minute, we want to claim our birth experiences as our own. We want to be involved in that process. We want to own feminine physiologic processes. We don't want to outsource them to an authoritarian provider or an authority figure or someone who tells us what to do with our own body. That's how midwifery was really sparked and brought to the forefront, back to the forefront in the United States. So it's really about centering control back to the woman and involving her in her care. So I'll just give a small example, a pelvic exam. I've been trained to always offer a woman a mirror as I'm doing a pelvic exam. If she wants it, she has the opportunity to learn about her own body, be involved with what's happening, and it's a learning opportunity, and it centers control. I've been taught to ask permission. I've been taught to, I'm just like trying to think of examples of in what way as a midwife. I've been taught to not just honor what the woman wants, but to honor birth and healthcare as a family event. So to include her family members to the full extent that she wants it. So there's a certain human connection between a midwife and a client, and we emphasize within the midwifery model cultivating a caregiving relationship. So I'm just going to describe the chairperson of SUNY Downstate Medical Center's midwifery program, who I have so much respect for, Ronnie Lichtman, and she's a doctorally prepared midwife. She has a PhD from Columbia. Her patients call her Ronnie. Her patients call her by her first name. They don't have a title in between. Do you hear what I'm describing?
So it feels more level.
Exactly. It's not a hierarchical relationship. It's an equalized relationship. Yeah. And that's part of why, by the way, midwifery is associated in the research with high patient satisfaction. It's for those reasons. It's that people feel higher level of control over their care. People feel participatory in the process, and that decisions are shared. So, yeah.
It's a huge part of it.
Yeah. It attracts empowered. It attracts people who want to make decisions in an empowered way and don't want to be dictated to. That's how I would like summarize it, you know, and that doesn't mean it's right for everybody. And I don't mean to say that midwives don't make recommendations. They do, but I mean to say there's an emphasis on empowering the woman in the process to that. So,
and from what I understand, this is just sort of like a logistical question, but from what I understand, you know, for someone that chooses to hire a midwife for their care, let's say during pregnancy, so those prenatal appointments could be 30, 45 minutes, an hour. Like, you have a lot of time with your client, but I personally given birth with an OB for my pregnancies, and I happen to love my OB, and I do think that she did engage in this, you know, shared decision making and options, and we had a very good relationship. But just practically speaking, those appointments were like less than 10 minutes. You don't really even have the time. So I guess there's certain limitations in the system itself, which is probably a whole different conversation, but that makes it, you know, how do midwives get that, or how do you make that happen in your practice for people to get that individualized care? Because there is this like time component. Are you taking on fewer clients? And maybe you could talk about accessibility to midwifery care. Excellent question.
That's such a good point. And, you know, like, I'm very fortunate. I don't run a high volume practice. So for home birth, we're high volume, but I need to say compared to a hospital-based practice, I don't have to see 4 patients an hour. I had the luxury this morning. I sat on a woman's couch today. She's having her baby in 2 weeks, around 2 weeks with us. And that might be 4 weeks, or that might be 5 weeks.
Right.
You don't know. Or 1 week. There's a range, and we're going to honor that variation of normal and her individualized approach. I sat on her couch today for 45 minutes, and I was able to properly answer each of her questions about birth control and offer her the full menu of options so that it's not just pills or nothing,
Right.
pills or pregnancy, right?
Right.
I was able to discuss with her risk benefits of vitamin K, what other countries are doing other than the American approach. So
Right.
patient education is strongly emphasized within midwifery model. And part of that is because for people to be able to participate in their decision-making process, you really have to share with them
Right.
accurate, unbiased, current information. And it takes time. And cultivating a relationship, I find as a clinician, it takes time. Like I got to hear from that mother about what she wants from her birth experience. Are we going to birth in the water? Does she want her mother to be there? Like when you get to really connect to the client as a human being, and it's not just assessing mother and baby and blood pressure and how much the uterus has grown, because that only takes 5-10 minutes. But when you really get to have that human component, firstly, it's rewarding as a midwife, but it really helps you help mothers have the birth experience they want to have and they need from that birth, right? Birth isn't only about safety. Having a safe baby and a mother whose body is intact, that's good.
That's baseline.
It's necessary to have, it's necessary to have a safe birth, but that's a low standard. There's so much more to birth beyond safety because there's a woman who's being born into motherhood. There's a baby who's having its first experience on planet Earth and is incredibly impressionable to that experience. So I'm just describing that's a very good point you're picking up about midwifery, that there's, because of that emphasis in cultivating a caregiving relationship, hopefully there's more time spent. A lot is also system, like you described. Being in a hospital setting requires having a higher volume practice to cover malpractice insurance premiums. The sustainability of such a practice depends on catering to a high volume of people. And institutions can, right? An obstetrician in an OB unit, labor and delivery, they can have 4 patients in labor at one time because they're all in one place. They can pop room to room to room. When we come to a birth, we're dedicated to that mother in labor. We're literally in our house. We can't have 4 mothers in labor simultaneously, right? So it's a totally different model of care. And that's why it can't be high volume. By definition, a home birth practice is like a boutique style healthcare practice. That's the reality.
Got it. Yeah, I think it's really important for people to understand these are not, it's about the provider, but there's also these like, just the systemic differences and that will really, how that will impact the care that you can receive. Can you just talk quickly? And then I really want to get into like the home birth myths versus fact and the whole safety. But while we're on the topic of like the systemic issues, I guess, so to speak, can you just talk about like the financial piece of this? Like you mentioned that home birth is kind of a boutique offering, and when I hear the word boutique, I think expensive and out of pocket. Do home birth midwives take insurance? Is this something that could be covered by insurance? How much does it cost if you pay out of pocket? Like just
amazing question.
Like how does that work?
Amazing question. In the state of New York, Medicaid covers home birth.
Okay.
And
that's fascinating.
That's amazing. And it's a big savings for the system between you and me. And that's why they do it, right? Like just think about the cost of having a mother in having a surgery or an induction or a baby in an ICU, all of which are proportionally much likelier to happen if that mother walks into a hospital versus if she just stays home and they only have to pay the midwife. They don't have to pay for a whole list of interventions. So Medicaid in the state of New York covers home birth. A number of private insurances cover home birth. And yes, I will tell you that the reimbursement that a home birth midwife gets, hopefully should reflect, and that's not true with all insurances, but home birth midwives dedicate a lot of time prenatally and during the birth process, right? Because a home birth midwife isn't relying on the nursing staff in a hospital to support the labor until the doctor shows up. The home birth midwife, when I get a call, if a mother's not sure if she's in labor, like I just went down to Williamsburg because we had a quick birther and thought she was in labor. Malky and we went down right away. And in the end, her baby decided not to be born that day and the labor stopped. We went home. I got another call a few days later. Rachi and Malky, my sister midwives, had been at a water birth in the middle of the night, a gorgeous water birth. And I went with a birth assistant to this mother in the morning. And again, by the time I got there, her labor stopped. And then on a third try, her beautiful 9-pound, 5-ounce baby boy emerged into the world, right?
Wow.
So I'm just describing to you the care of a good home birth practice is involved, is dedicated, and we don't have that institutional infrastructure where the nurses process a lot of like the early part and then the doctor's called in. And I love that. I love it that I'm the first person the mother meets in her labor, not a nurse. I'm the familiar face that greets her when she's in labor, but it's a very different model. Absolutely.
It's very, very different. So the whole experience is very different. And I think one of the questions I had, which I think we've just alluded to, some of the reasons why someone might choose a home birth are these things like you're getting this completely different model of care, and that could really appeal to people who want to be more involved in their decision making, who want a more personalized touch during their prenatal care and their birth. So obviously feel free to share more reasons as we get into some of these other questions, but let's get into like some of the myths. So the number one question I have heard from people is, what if something happens? What, in those words, what if something happens? Meaning, what if there's an emergency at home? Okay, let's say someone's chosen to give birth at home. You know, everything is fine in their pregnancy. They're, you know, low risk. They don't have any medical complications. And during the birth, something happens. So can you talk about that piece of it? You know, some of these safety concerns that is like top of mind for a lot of people. Like, for example, someone just put in, you know, Bonnie said, what happens if mom needs an emergency C-section or a breech baby, which is kind of like a separate thing. But let's talk about an emergency. What do you do? And also specifically, what are some of the examples of emergencies that could arise that would warrant a higher level of care?
Excellent question. So I want to take one step back, Lauren, to properly address this question, to say home birth in an industrialized country is not like home birth 200 years ago. We're not going back 200 years and rebelling against modern advances and Western medicine. Home birth in an industrialized country means three things. One, there's appropriate client selection, which means it's catering to risk-appropriate mothers who have prenatal care, and mothers whose risk profile, based on their pregnancy, makes it suitable for them to give birth at home. 200 years ago, somebody with uncontrolled high blood pressure gave birth at home, not by any choice, but so they had so that's one piece I want to mention. Number two, midwives are trained to handle birth emergencies. They're not just hoping for the best. And they bring Western medicine, medications, resuscitation equipment, oxygen tank, first-line medication, second-line medication, third-line medication. We carry fourth-line medication in our practice, NIV for a hemorrhage, God forbid. So they bring what's available in a hospital. Some of what's available in a hospital comes with the home birth midwife to the person's bedroom, literally. And usually we don't need it, but we have it. And in the unlikely event that an emergency were to exceed that which a home birth setting can deal with, which is not common, not likely to happen in a risk-appropriate population, then a safe, responsible home birth midwife transfers to the hospital and facilitates a professional, seamless, timely transfer. So it's not that every planned home birth means by hook or by crook that baby's being born at home. In an industrialized country, we're grateful for the hospital system so that those rear mothers who at home indicated that they need a hospital system, then they can get the benefits of that. That doesn't mean we recommend that every last person, regardless of risk, hospitalize themselves to have a baby. We know that we can profile and say people with a healthy pregnancy, a single baby, head down, who's term, right? They're past 37 weeks. Something like that. We know that when those mothers are attended at home with a qualified midwife who has medications on her, who knows not to intervene, knows not to interfere with the labor process, knows to honor the physiology of labor, we know that those low-risk mothers, when they're at home, they have at least as good outcomes as if they hospitalize themselves. And quite the contrary, they actually have better outcomes. And I want to show the data. I want to screen share the data. So nobody has to trust me. And I want to show New York State's home birth outcome data because I'm so proud of it, to be honest.
Yeah.
And I want to showcase it so that people can see that choosing a home birth, it may not be for them, and I'm going to go into why it may not be for somebody, and people themselves know what is or isn't for them. But what I want to show is that it is a valid choice because it's also a safe choice.
Right.
And an emergency can happen at home.
Yeah.
Malky Schuler and I love Malky. Malky is a midwife in our practice. Malky graduated first place from SUNY Downstate's midwifery program. And she worked as, and is a close friend of mine, and she worked as a labor and delivery nurse at NYU for 7 years, okay, before becoming a midwife. She has seen the gamut of emergencies. There's one life-threatening emergency that's so rare that she said she doesn't think she's ever seen. But she has seen in 7 years at NYU the gamut of major emergencies. And she has told a prospective client today in a consultation, every emergency she's seen, virtually every one, she is capable of tracing back to an intervention that became a cascade of intervention that ended up in an emergency, and then luckily those people were in a hospital because they really needed to be rescued, and they needed the infrastructure of a hospital. They needed an operating room. They needed a surgeon. They needed that neonatologist. They needed that equipment. But if we would take those steps back, that emergency in a home birth setting would not have happened. So an emergency can happen at home even though we don't cause them, meaning even though there isn't that cascade of intervention, an emergency in rare circumstances can happen even at home, even with a low-risk mother. But part of responsible home birth is to have a qualified midwife who would know how to handle an emergency, and a qualified midwife who can stop a hemorrhage, who can resuscitate a baby, give a baby a few breaths, a midwife who listens and monitors the baby during labor so that she can know, is this a baby who's indicating it needs to be born in a hospital, and transfer that baby in the rightful time and pick up on those signals in the rightful time. So it's not that the midwife's showing up and just saying, well, this is a natural process, so it always works out. We're showing up and saying, this is a natural process, so we're going to trust it and be humble to it, but we're going to be clinically astute and pay attention so that for the minority of people that run into trouble, we intervene quickly and appropriately. I want to mention, I have witnessed very serious emergencies in a hospital setting. I mean, I've seen mothers in ICUs who had cesareans that they never should have had. And the New York State Department of Health website is very clear. Most people who die in pregnancy, and that's a catastrophic bad outcome, they had a C-section, okay? So my professional experience of what I've witnessed in a hospital is very much representative of what the outcomes are across New York, that interventive deliveries are associated, surgical deliveries are disproportionately associated with catastrophic outcomes. Medical inductions, giving people Pitocin, we don't give people Pitocin in a labor at home. That's an intervention that requires ready access to an operating room, because having Pitocin in a labor isn't like eating an organic cucumber during a labor. That drug affects the baby potentially, right? That's a mother who benefits from having continuous monitoring, because you have to keep a very close eye on how is that baby tolerating a strong drug like that, right? A low-risk mother at home, we monitor them appropriately, but that doesn't necessitate, physiologic labor doesn't necessitate that kind of monitoring, right? But the point I want to make is that I've witnessed very serious emergencies. And what I find so fascinating is that people will routinely ask me, what was your worst outcome that you've had as a home birth midwife? And I sometimes ask myself, and they should ask me that question, because that's part of making an informed decision, and I respect that. But I sometimes question, in New York, where there's such a comfort with intervention and a hospital system, people ask that same question to their obstetrician. What was your worst outcome? How many mothers have ended up under your care in the ICU And was that outcome preventable?
Yeah.
People don't ask that question. There's an assumption and a cultural prejudice that if something goes wrong in a hospital, it was despite being in a hospital. And if something were to go wrong at home, it's because they were at home.
100%.
But I'm trying to make the point that there are emergencies that happen in hospitals that could have been prevented from being at home.
And that's
When
I just wanted to say that is a hard pill to swallow.
Oh, yeah.
Who are accustomed to giving birth in a hospital, and everyone they know has given birth in a hospital, because 98% of people in the United States give birth in a hospital. That honestly is that fact is it is a hard thing for people to really wrap their minds around, because, like you're saying, there is this cultural bias to trusting Western medicine unconditionally, but we don't hold the same standards for a home birth and a hospital birth. Are we and I think it's a really good point. Are we asking those same questions? What would you say to someone who says, okay, I understand, Judy, what you're saying. Interventions can have unintended outcomes that can cause bad outcomes. What if I want to just give birth in a hospital, but I'm going to decline all the interventions?
Excellent question.
What would you say to that person? I'm not going to get an epidural. I don't want to get induced. I'm going to decline Pitocin if it's offered to me. I'm going to have intermittent monitoring, not continuous. But I'm still going to be in a hospital because, like, it makes me feel better. What would you say to that person?
Excellent question. I love that question. I have relatives who make that choice, by the way. I love that question, right? And I want to, and I do want to mention, by the way, with Pitocin, there are times that Pitocin is indicated and Pitocin has saved people's lives, but the overuse of Pitocin has caused a lot of trouble that could have been prevented. That's what I want to say. And there was one other thing I want to mention, that the rear bad outcome from home birth, some of them could have been a bad outcome anywhere, and that a hospital wouldn't have saved that baby. Some of the rear bad outcomes from home birth, it was that provider who wasn't properly equipped, wasn't properly certified, wasn't properly prepared, and that a better home birth provider wouldn't have had that outcome. So it wasn't the home birth setting, it was the provider, right? And the third possibility of the rear bad outcomes from home birth, because they exist, is that that baby would have not had that bad outcome in a hospital, and that truly that delay in getting to a hospital setting made the difference.
Yeah.
But you have to think about the bad outcomes for babies in hospitals, also rare for low-risk mothers, that would have been prevented from being born at home. And because that number isn't higher than the number of bad outcomes for babies at home, it makes home birth a valid choice. And for that one person, it's horrible and it's a tragedy, but it doesn't mean that on a population level, everyone should run to the hospital, because there are those rear bad outcomes from hospitals that could have been prevented from home birth. And the specific benefits of a hospital, you should just know, when I tell people that home birth is safer than having a baby in a hospital for a low-risk woman, I wanted to share with you, it is, based on New York State's home birth data, a New York State Alliance for Licensed Midwives best practices for community birth, where they summarize the data on home birth. A risk-appropriate mother who gives birth at home with a licensed midwife, where there's ready access to a hospital system, where they had appropriate prenatal care, and is safe, responsible home birth. I want to show it on the screen, but the rate of perinatal deaths are very low. The rate of babies dying are very low and comparable to those in a hospital, so it doesn't put the baby at risk. And the rates of complications for mother, from minor complications to major complications, are all reduced by staying home. Overall, being at home becomes safer because it's lower risk to the mother and doesn't increase risks to the baby. So home birth is more than a valid choice. It doesn't mean it's for everybody who's low risk, but it's a valid choice.
And is it true that the main reason for transfer to a hospital during a home birth is because a mother decides that she wants an epidural for pain relief, which isn't something that's available at home? Is that true?
Really good question. Most transfers for home birth to hospital are first-time mothers. I mean, most first-time mothers who plan a home birth give birth at home, but transfers are disproportionately first-time mothers in New York, in the United States, and globally. And most of those transfers are not emergencies. Most of those are what you just described. Maternal exhaustion, wanting pain relief, labor's gone for days and hasn't gone anywhere. It's not like a boom, crash, we got to get to the hospital
Yeah.
in an ambulance.
That's what
So
people
that's
think.
a very
Yeah.
good point. That's a very good point to make and a very important point to make. And every hospital in the United States is legally, federally, on a federal level, mandated to receive a home birth transfer. So if a person decided they wanted to get an epidural and they have the right to make that choice, and a good midwife will honor that, they'll support them at home. But I've never, Baruch Hashem, had to transfer a mother who wanted an epidural, just so you should know.
Yeah.
When you're laboring at home in your own environment with really good support, and you're able to be in a shower and no one's coming at you with an IV, and you're mobile and you have the familiarity and comfort of home, and you're not tied to a bed and you're not tied to an IV and monitor with nurses coming in and out. Baruch Hashem, we've never had to transfer a mother for an epidural. But I have to say that a good midwife will honor a mother's choice and a mother's preference, and she will facilitate a transfer even for a non-emergency. And every hospital is open to a home birther to get either emergency care or an epidural, and the midwife will give the charts over to the hospital so they don't have to retest her blood type, meaning there will be a professional transfer of care. The midwife will give report, and the person could show up and get an epidural. They're not locked out of it. Hospitals are open 24/7, and they're required to take you. So that's good for people to know. It's a good question. What if a person says, I'm going to choose a provider who's less interventive, and I'm going to come to a hospital and have a less interventive experience. I'm not going to sign up for an elective induction at 39 weeks if my pregnancy is thriving. I'm not going to sign up at 40 and a half weeks if my pregnancy is thriving. And I'm going to labor unmedicated to the extent that I can. If a person walks into that, to a New York hospital, then I don't think they're going to be a New York statistic, right? An American hospital has one of the worst outcomes in the entire industrialized world. That's the reality. In the last 20 years, as the C-section rate has steadily increased in the United States, outcomes have deteriorated, and outcomes have gotten worse and worse and worse. So having a baby in New York relative to the rest of the industrialized world is quite unsafe to walk into a New York hospital. Not one New York City hospital and not one Long Island hospital. I just looked this up on the Department of Health website. Not a single hospital in this area has a C-section rate that meets safe thresholds according to the World Health Organization.
It's crazy, by the way.
I
feel it's in New York. I think New Jersey also publishes it. No, the C-section rates, at least in our community where we live, they're like hovering around 40%.
Right, and right. Yeah, exactly. In Long Island, in Nassau County, it's 37.8. In New York State, it's 34.4. That means that it's about triple what it should be. So most cesareans were preventable or unnecessary, and it was either a result of a cascade of intervention, one drug leading to the next, one intervention to the next, and then luckily they were near an operating room, or it was just unnecessary even in the moment. But that was most cesareans in New York can meet that criteria for a low-risk woman, absolutely. But that being said, a person, if they chose to do a non-interventive birth in a hospital, then I don't see it as the same risk as just walking into a New York hospital. But I want to mention three things. One,
so meaning if someone chose to have a more low-risk birth, then they could mitigate some of those risks, even if they're in a hospital.
Right. Exactly. I don't want to, clump all hospital births without identifying different birth choices and the risks associated with those birth choices. A person who walks into a hospital and says, I'm going to labor at home till late. I'm going to show up and not get an epidural. I'm going to use a provider who's going to be respectful of my choice, that I don't want Pitocin, I don't want my uterus to be broken. A person who's making those conscious choices will mitigate their risks. But I have three things to say to those people.
Yeah, I also have some thoughts. Go ahead.
Lauren, you're first, because you're full of so much wisdom. You tell me what your thoughts are for those mothers. Yeah.
Okay, well, so the first thing is, if you can make those choices to say, I'm going to decline certain interventions, I'm going to prepare myself to birth without an epidural. But I do think I have learned this, I guess, through my personal experience and also just working with expectant families and hearing people's experiences, that just by nature of walking into the hospital, I wonder if, even if you're going to decline them, are those things going to be offered and potentially pushed on you more so, it's going to be a harder battle to fight, I guess, than it would be at home, where you're participating, like you said, more in shared decision making. Like, I'm going to offer this to you as an option. What do you want to do? I know I'll speak from my personal experience. By my first birth, I didn't want an epidural. There was someone coming in my room every half hour offering me an epidural. And, you know, so I think that someone could go in with like the strongest conviction ever. And that's super important. And I always talk about that. Choosing your provider, choosing your place of birth those are two hugely important factors in how your birth unfolds. And you have to be, I think people just also have to be realistic about just the environment and how that might change in the midst of labor. So I'm just going to say one more thing. You know, if labor is progressing, but it's slow, you as a home birth midwife might say, okay, you're progressing, it's slow, but that's within the range of normal. But in a hospital setting, it's progressing, but it's slow. Okay, well, now maybe someone diagnoses that as too slow, and now we need to start Pitocin. So I think that the standards and like the criteria of assessing what's normal and what's outside the range of normal are different between a hospital and home.
Well, you just said that, yeah.
So that also is going to be something that people need to consider that can change, change how their birth is going to unfold in either place.
Totally. I love how you just articulated that. We just use different criteria. We view labor as different. We have a different level of patience toward it, right? We honor the process differently. But I think my answer is going to be very similar to yours. I have a few things to say to people who want to choose that less interventive birth. My first one is that you're right. It will mitigate risks. Staying home, coming in late, birthing unmedicated, birthing with a provider who will honor that will mitigate risks. But I have three things to say. You're still gambling with your birth process. And the reason is straightforward. There's no way to predict how that labor is going to unfold. What if you carry your pregnancy a little too long beyond your provider's comfort zone? Can anyone predict that? I just got an email from somebody like that who was considering a home birth and then ran a healthy pregnancy and then just ran into the risks of having the complete arsenal of Western medicine's capabilities when it comes to a medical induction deployed at her, because her pregnancy was just a little too long for the provider's comfort zone. Number two, what if a person, their water releases and they don't start labor, and now it's 12 hours and 24 and 36. The guidelines within a hospital-based setting and a home birth setting are going to be very different. A very home birth practice will follow the home birth guidelines for releasing water, and that's a variation of normal. And based on the criteria, they could have much more patients. They won't do vaginal exams. They'll do it differently and safely, but they'll give you options to avoid a medical induction that a hospital-based provider may not be able to offer, either because they don't know about it or because their institution can't walk into the hospital where they have privileges violating institutional policies that govern them. You give up a certain level of ownership when you walk into an institution because you have to abide to some extent. The provider has to abide to their rules,
I put it as like it's not bad or good. It's just the fact you're birthing on someone else's turf, so you kind of have to play by the rules to a certain extent, which might work in your favor sometimes and might not work in your favor other times.
Exactly. You're a guest, You're a guest within an institution. Now, legally, a woman has the right to decline all intervention. I want people to know that. The hospital is required to admit them if they're in labor. The woman has the right legally to decline all intervention, even life-saving intervention. So if they say it's life-saving, and I'm not saying decline life-saving intervention, but I just want people to know their legal rights. With a baby, it's different. With a newborn, it's different. But for the mother, she has the right. But I do want to mention, so a small variation of normal can end up in a medicalized birth with a person not able to predict it. The second piece I want to say is that nobody either knows, let's say they're going to be continuously monitored just for 20 minutes when they come in. No one could predict if that baby is going to have a few decelerations. And then what's that person going to do when their provider says your baby could die if we don't do a C-section, right? Or if we don't get this baby out, like there's no way to, if you're not coming in knowing how to interpret a monitor, you're really coming in trusting a surgeon if you're choosing an obstetrician, or you're coming in trusting that midwife. At the end of the day, if you're in a setting that has higher rates of intervention, like C-sections, you can assume they have unnecessarily high rates of vacuum deliveries, of episiotomies, of Pitocin use, of vaginal exams, of inductions. It's a picture. It's not just, oh, the C-section rate is triple what it should be.
Right.
It means all intervention is higher than it should be.
Right.
So you have to ask yourself, are you setting yourself up for success? Or are you gambling with your birth to a degree that you don't want to take risk with? And it's unknown what that risk is.
Right.
If you go to a Chinese restaurant and you want a pastrami sandwich, you're in the wrong place, right? It doesn't make it bad that you want a pastrami sandwich.
Right.
You just need to set yourself up that the people catering to you know how to make a pastrami sandwich. So if you're looking for a non-interventive birth experience, then going to a setting and with a professional who does that all day long, you shouldn't need a birth plan. Meaning, if you need to tell your provider, I don't want you to clamp the cord 60 seconds after my baby's born, is that provider going to really remember? Are you going to need to fight for it, advocate for it, and instead of loving your baby, you're going to be guiding clinical management? Or can you just choose a provider who every time they go to a birth, they wait 30 minutes, 5 minutes, an hour? Just choose a provider who does that routinely. That's like my recommendation for people. Think about the birth you want to have and choose the professional who does that routinely.
Yeah.
So if you want to have a medicalized birth, and I'm completely supportive of birth choice, and I want people to know that, I don't think that home birth is for everybody just because their risk factors clinically would say that they're safe at home, right? Birth is an emotional process. You have to feel safe in your environment to labor one. You have to want to be there. To tell everybody who's low risk to birth at home is primitive. It's like going back a few hundred years. To tell people that you have the option to birth at home is progressive, right? It's supporting birth choice. So I don't think that everyone should have a physiologic non-interventive experience. Do I think it's healthiest for mother and baby? It is, and that's well substantiated by research, that giving a baby an unmedicated birth is a gift to that baby. That those babies do better, right? But I still think women have the choice to choose otherwise. And I'm grateful that those options exist. So if you want a medicalized experience, choose someone who that's what they do for a living, and they're proficient at that. It's like if someone needs a surgery or wants a surgery, I recommend a qualified surgeon, not someone that, oh, you want surgery? Yeah, I think we could accommodate you for that. So if you want to have a physiologic birth, to use a provider who's never seen a physiologic birth, I've never personally witnessed a physiologic birth in a hospital setting. They do exist, but I've never witnessed it. So it's rare. It's not common. And I'll describe what a physiologic birth is in a minute. But a physiologic birth and unmedicated birth without an epidural are different. So, but if you want to have a physiologic birth, to show up to a professional who's going to say, so tell me how to do that. You tell me the plan of what to go about it. Is that a setup for success? That's my question. The other thing I want to mention is that the baby is having an experience too. And that setting the energy for a newborn to be received in an environment that facilitates love and trust to be imprinted on that baby's cellular memory should not be undervalued. Being in an environment that's stimulating, that is disruptive. Now, it doesn't mean you couldn't have a baby in a hospital and tell people, please honor those moments and make them skin to skin and delayed cord clamping, and let this be the cocoon of ecstasy and love and triumph and relief that birth brings. You can ask hospital staff to do that, and hopefully you're going to have a respectful person. But it's like, do you get to choose your nurse during your labor process?
No.
It's there are gambles in that choice of saying, I want to have a non-interventive experience in an environment that's steeped in intervention. That's all. It's people should make an informed choice about it, you know, and if it's right for them, they should go. And the other consideration, of course, is you're traveling during the labor process. And I think one of the benefits of laboring in your own environment is also that you're not caging yourself into a car during an intense part of labor, But I've heard of women who have gone to hospitals, and for full fairness, I know of women who they didn't go too overdue, they didn't release their waters for too long. Their process followed the guidelines that a hospital dictates, and they didn't labor for too long, and they showed up and their labor's progressed, and they had providers who honored their preference that they shouldn't get an IV. They didn't have to be at birth and at war at the same time and fight for it. They compromised. Maybe they got a hep block. They compromised maybe. Or they birthed and they got to birth on hands and knees or all fours or kneeling because they chose a midwife who was going to, or a doctor who's going to be supportive to that. And I don't want to be prejudiced for or against, and they chose that. And they had delayed cord clamping and skin to skin contact, and no one told them to hold their breath as they were pushing. They birthed with their instincts, and physiologic pushing typically looks like this during a contraction, not push, hold your breath. Physiologic pushing isn't prolonged holding your breath. It deoxygenates the baby and it exhausts them. Right. And it bursts blood vessels potentially. So I'm just describing to you, there are definitely mothers who have had gentle births in the system. I just mean to say the statistics are not high in their favor to have a physiologic birth in a New York hospital. So people should be informed. The other piece we should mention, and even with an epidural, you can choose a provider who will be less medical minded. I just want to say that it doesn't have to be that people throw in the towel. Like there's different levels of medicalizing, right? I've been at a birth where they wanted to augment the mother and she was on an epidural and she used a breast pump as she was on the epidural to augment her labor rather than Pitocin. So I'm just describing to you, right? But I'm just going to share the reality. Satisfaction with home birth is very high. People who want physiologic births who go to a hospital, they manage to finagle it, or they were lucky.
It's a lot of work.
It's a lot of work. That's what I was describing. I want to give people the reality.
Exactly. It is. I know.
Yeah. Right. And I have a funny question to ask. What if they're GBS positive, Group B strep positive? Are they going to be offered anything other than the American approach? And if they decline the American approach to give every last Group B strep positive mother antibiotic, what's going to happen to their baby? Is their baby going to be taken to a NICU, right? What are the ramifications of that decision, right? At home birth, if you're using a good informed home birth practice, and in New York City, there is so much talent within the healthcare, but in the home birth world, there's so many terrific home birth providers, then you would have the menu of options of what's being done in other industrialized countries that are other reasonable, safe strategies. And remember, like every vaginal exam is an increased risk for an infection. You're going to birth with a provider who's going to be cautious with that. When a baby born in a hospital ends up in a NICU because of an infection or something else, no one looks at the parents with blame and says, you birthed in a germ-ridden environment. Why did you do that? Now your baby has an infection and is in the NICU. Or why did you let them do so many vaginal exams? Those are well correlated in the research with an infection, right? There's no judgment to it. So it seems like it was unpreventable. And I'm not saying there should be judgment to it, but I mean to say, like, people who are birthing at home, that rare chance our baby ends up in a NICU, we all know how much blame and finger pointing those parents potentially will need to face.
And that just goes back to that, like, cultural bias. We're not applying the same standard. And I think
exactly.
You have to be intellectually honest when you're looking at both options. And that is not something that I've seen when it comes to the conversation around hospital versus home birth, which is why we're having this conversation now. Because people are, certainly biased towards favoring the hospital. And not that that's, it's not bad, it's just unfair. Like, you have to be honest when you look at both options, to see which makes the most sense for you, and see the facts around home birth, which you've articulated, that it is safe for, just to sum up everything, right? That it is safe for someone who's risk appropriate, that they are with a qualified care provider. What was the other thing you said?
That they get good prenatal care.
Good prenatal care.
Have regular assessments, that they know they're risk appropriate,
And one other thing that I was taking away from what you were just saying is when it comes to someone's birth, this is something that's a huge sticking point for me, is that educating yourself around the choices available, meaning your care provider and your place of birth are two tremendous factors that influence how the birth is going to unfold. And through this conversation, I sort of had this light bulb moment of, there is also this element of unpredictability when it comes to birth. Like, you don't know if your water is going to break first or release first, right? Before your contractions start. You don't know if your labor is going to be slow or fast. And I think that what I'm hearing you say is that putting yourself with a provider who is going to make space for a range of normal, instead of trying to fit everyone into a narrow box, and if you're outside of that box, now it's a problem and we have to treat it. And that's a very, that to me feels like a very delicate balance, and it can be a very hard thing to figure out, right? So do you have any like, I guess, suggestions for questions that people can ask when they're trying to find a provider or place of birth that they can use to sort of piece together that picture? Like, how flexible is this going to be? Am I going to be shoved into a narrow box, or is there going to be space for things that might be outside the, a little more flexible, I guess?
That's such a good question, because people choosing providers who are respectful enough to, like, quote, stay out of their way. Like, I've heard that description. Like, if I come in informed and I know what I want to do, the provider will stay out of my way. Those are really important questions. Like, GBS positive, releasing waters, how long can you be pregnant for, birthing, what birth position, delayed cord clamping, how long can we delay cord clamping for, a full hour of uninterrupted skin-to-skin contact, but also like physiologic pushing, what's their intact perineal rate, right? Do you want to rip your body open during pregnancy, like during the birth process, right? Like, those are the muscles that control a person's ability to be continent when they're older, right? Those are the muscles that control sexuality. Those are the muscles that hold your pelvic organs in place. To just rip them open, like, should feel uncomfortable to people. To need to be stitched up should feel uncomfortable to people. Are you birthing with a provider who has a high success rate with keeping mothers' bodies intact, right? That's the role of the provider.
That's a huge topic that I see from my students, from people here on Instagram. Can we talk about that specifically, like with tearing?
Totally.
So as a home birth midwife, what is the difference between your intact perineum rate, meaning no tearing, versus the intact perineum, for someone birthing in a hospital setting?
Sure. The research is very clear. One of the benefits of home birth that we've listed as, like, for the mother is not just prevention of serious complications, like a postpartum hemorrhage is less likely to happen at home. Not that that necessarily is serious. Some of them are mild, but, or cesareans, less likely to happen if a person's home birthing. But tearing, laceration rates are higher in hospitals. And most people who have a baby in a hospital, according to the American College of Obstetrics and Gynecologists, mainstream medical resource, most people have a laceration, and most vaginal births, and most lacerations are second degree, which means they extend into muscle. A home birth practice, in our home birth practice, the majority of our mothers are intact perineum, including first-time mothers. It's very rare that I've stitched anybody up, Baruch Hashem. So that's, and that's not just, I feel so proud about that. I'm so grateful for that. But physiologic birth is protective of the human body.
But what are some of the things that you do that make the difference?
That make the difference. Our mothers are amazing. Like, when we guide them, let's say, to breathe it out and slow it down, they do. They protect their own bodies, right?
So you slow the birth of the head.
I was going to say that. Right. Letting the body adjust to the circumference of the head rather than giving that final push where the perineum goes from this to this, but letting it gently stretch, protective. Just, if it feels like burning, just, breathe that baby into the world. We use oil sometimes, I have to say, like olive oil or avocado oil. I try to avoid a lubricant, because we don't want the baby to swallow that on the way out. It's like, it's going to become the seeds of the baby's microbiome, so we'd rather an oil that's safely edible. We do all different things. We pulled the baby out if we felt that was the right thing. Like, for a mother who had an extensive episiotomy scar and we wanted to birth that baby incredibly gently, we just put counter pressure to the perineum or created perineal slack, like to create room. We've kept the head well flexed, which means keeping the head very downward so the back of the head gets born and the baby doesn't just do this. If the baby's a compound presentation where we had a hand with a head, instead of letting the baby do this and tear the mother, we held the hand very close to the head. But I would say slowing it down and birthing in a good position, like hands and knees, kneeling, what feels right to your body, and not doing that prolonged pushing, that closed glottis pushing, like hold that push. Just birthing very slowly at the very, people shouldn't hold our breath at any point like that prolonged, especially at the end,
Right.
to breathe it out slowly and be in a good birth position. I don't think it takes so many skills to keep someone intact like that. That's what I think, you know.
And
Someone with extensive,
no, just everything you're saying, it's like it feels as important to you to help the mother avoid a tear as it probably is to her. And I wonder if that prioritization is the same for all providers. Meaning, you know, like you're doing everything in your power because intact perineum is something that's important to you. And I don't know that that is as important across the board. Which is tough, you know what I mean? And people's options are more limited outside of a home birth setting in terms of birthing positions. You know, 90% of people are birthing on their back because that's how their provider maybe was trained, but that doesn't mean that's best for them. So there's all these, you know, other, you know, there are these limitations that don't exist in a home birth setting that allow you to really like prioritize something like intact perineum, which might not be prioritized in a hospital setting. They're like, okay, are you healthy? Your baby's healthy? Great. Okay, bye, go home. Okay, you have a second degree tear. It's not such a big deal. It's not true. It's a big deal.
It's a big deal. It's a big deal. And I want to say why it's a big deal. It's a big deal because it affects the mother's recovery and her pain in the immediate recovery process. And the idea of weaving a needle into a woman's sensitive part of her body. Firstly, every time you weave the needle, you're puncturing the tissue. It's more trauma. So and to leave a foreign material there creates an inflammatory process for the body to eat up the stitches. And for a mother who just birthed a baby to need to deal with a wound, it's not natural to need stitches. And I'm not saying it's always preventable, but the majority of tears, like majority of mothers should birth without needing a single stitch, or if they have a very small tear, it doesn't necessarily need to be stitched up. It doesn't necessarily benefit from being stitched up. I think that birthing with a midwife, the research does support that midwifery model is associated with more intact rate because we're not surgeons. It's like we don't have that cut open the body. It's just not our profession. It's a more, hopefully more gentle profession. I would say being intact and having an intact perineum has so much value for long-term pelvic health. Do you know the current rates in the United States are that the majority of women are incontinent of urine at the age of 65? Like, I hope that women live to the age of 65. The numbers of women who by age 50 are incontinent of urine is also over 40%. Like, that's really significant. Like, to me, if those muscles are protected properly, they shouldn't be ripping open and then have scar tissue and then be expected to function normally. I'm not saying the body can't heal. It can. And the body's resilient, and pelvic floor physical therapy can be extraordinarily beneficial. But preventing damage in the first place is the responsible approach from my perspective. You know, and a healthy baby is one responsibility of the provider, and a gentle birth for the mother's body is a second responsibility of the provider. It's not like I told my sister once, you know, I never ever had to stitch up a multiparous woman. Baruch Hashem, if I've received that baby in this practice, I personally have never had to stitch up a woman who's previously given birth before. And my sister looked at me and said, that's your job. And she's right. So I'm just saying, she's right. It's the role of the provider to protect a woman from damaging her body. Exactly. And to facilitate a gentle birth, and to ensure, of course, the safety of the baby, and to ensure that that mother, to the best of their ability, has the experience they were seeking to have, that they should feel empowered, that they should feel transformed by the birth. It's not only about a healthy baby and a whole body, the mother's body is whole, that they leave that birth feeling that they live in their body differently. They inhabit womanhood differently. They mother their child differently because of the birth process. That's what birth has the power for. So because you never have a second chance to rebirth your baby, that's the reason making informed decisions that will help you have the birth experience you want to have. And for every person, that's different. And every person knows what they want deep in their heart. Choosing a birth setting and a birth provider that you don't have to tell them what to do, but is aligned with what you want and will make it most likely for you to have that birth is key. because there's no second chances, and you will never forget your birth. I want every mother on this
You won't.
Instagram Live to know I have never yet met a woman who has forgotten her birth.
For sure.
So if however much time you research which car to buy, which iPad to buy,
Stroller, car seat.
right, at least as much time, right, at least as much time research your birth provider. And knowing two friends who birthed well with a particular provider doesn't necessarily make it safe. It could be that those friends birth quickly, birth like we described, within the dictated box that they need. Right, exactly. Having a thorough interview is key. And again, the single greatest risk factor for having a C-section, choice of birth setting. So, Lauren, I respect you so much for truly offering people birth choice. To truly offer birth choice is to inform people of all birth settings so that they can have the menu of options, not just within a hospital, but the full menu of options that exist to them are accessible and affordable to them in an industrialized country.
Amazing.
Like, it's available. Every year. You could go online, you can find home birth midwives, you can interview them, you can get good care right in your bedroom, you know? So, yeah.
People do have options and more than they realize. So that's why we're having this conversation.
Absolutely.
Someone just said planning to do a home birth, but I was feeling nervous about it. Now I feel excited. Thank you so much.
Great. I'm so happy.
Thank you so much, everyone, for joining. Is there anything else that you wanted to share that we didn't cover? And then we're going to wrap up. Oops. Hold on.
I love you. Can you do
it?
I love you. The answer.
Someone asked that question in another live you did around home birth.
Yeah,
remember.
I love it. I love that question. I'll tell you the reason why, to my knowledge, for sure not in the United States, but to my knowledge, it doesn't exist in a home birth setting in an industrialized country, to my knowledge. And the reason is straightforward. An epidural means the baby's getting bupivacaine, epinephrine, and fentanyl, right? Fentanyl is an opioid. Those medications pose risks to a baby that necessitate ready access to an operating room. If a woman were on an epidural at home, we wouldn't have the outstanding home birth outcomes that we do, because the risks of that medication wouldn't be appropriate for being in a home setting. Also, sometimes it immobilizes a mother. So that can create another impediment in the labor process, which is another level of risk. But I want to tell you, I personally, in a hospital setting, have helped a mother onto her hands and knees on the bed. So even within epidural, people can choose, and they don't have to just relinquish everything because they've made a certain choice, and people should know that, you know.
Really important point. I talk about that a lot in my classes too.
Really?
That's amazing. Yes, it's not the end all be all. There's a lot more.
Right.
But an epidural is not available at home. Sorry, I'm just looking at some of the questions we had, and I think I shared that by accident. Again, I'm not really good at Instagram. Hold on.
Oh, sure. I'm not going to be the one to help. That I can't help with.
I feel like we went through all of these. Oh, someone said, can you have a home birth if you have a small apartment?
Yes, babies don't take up a lot of room.
Yes.
I've been in such tiny apartments, and the joy and love that emanated from those tiny Brooklyn apartments filled the planet. And I want to say something else about the epidural. Sometimes people think they need an epidural based on their past hospital experience, and I want to reiterate that being in a hospital setting unmedicated without an epidural is very different than laboring at home without an epidural. Mm-hmm. You're not caged into a small room in your house. You're able to be in a shower. You're not tied to an IV on a monitor. You're not being interrupted. You could have midwives who could be incredibly supportive, who can counter pressure your back. It's such night and day.
Totally. And also just on a hormonal level, all of those things help your oxytocin flow, which helps contractions. That releases endorphins, which is natural pain reliever. So you also have your body working in your favor.
Amazing. Such a good point, Lauren, that physiologic perspective. And also, you're upright, you're mobile, your labor will move quicker likely than lying on a bed. So if someone felt they couldn't do it without an epidural in a hospital, it's not an indication that they couldn't do it without an epidural at home. I want to share something, even though people are going to tell me that I was proselytizing. I want to still share something. We've received babies of mothers who've had epidurals in a hospital. And of course, an epidural is a gamble. Many of them work, some of them don't. We've received babies of mothers who had effective epidurals that really numbed them. We don't have a single such mother who's ever planning to go back for their epidural.
Right.
Those mothers home birthed and felt not just they felt they could do it, they did it in a way that left them feeling amazing about their experience, which to me is enlightening, that they've tried both ways. And that was very fascinating to me.
Right.
You know?
Interesting. Yeah.
Right.
Yeah. They're
Right.
way back. Someone,
Right.
does a VBAC disqualify you from a home birth?
Excellent question. In the state of New York, a VBAC, I want to just distinguish somebody who's had a vaginal birth and a cesarean versus somebody who's had a cesarean and no vaginal birth.
So if someone there had a cesarean birth and that was their first baby and they haven't had any subsequent children, okay, so that's one.
That's
right?
one
And then the other thing you said was if they had a cesarean and then subsequently did have a vaginal birth. So
yes, and another scenario is somebody who's had a vaginal birth and then a cesarean. So they've never had a vaginal birth since the cesarean, but they have birthed vaginally before.
Right. Okay.
So those are different people. It's not like VBAC is one sweeping answer. Okay. All of them have access to home birth in New York. All of those VBACs have access to home birth. Yeah. But and there are a lot of practices that will attend all three types. But outcomes are different for those different scenarios. Somebody who's already had a VBAC, they're lower risk than a low risk first-time mother. Okay. They have better outcomes across all measures, all outcome measures, than a low risk first-time mother. If someone's had a cesarean and then a VBAC, their next subsequent VBAC, that's how they should know that. New York State home birth guidelines quote that for somebody who's had a history of a vaginal birth and a C-section, they're lower risk than low risk mothers. I don't know for sure if that includes people who've had a vaginal birth before the C-section. It could be it does. I don't know that. Okay. But it is a different category than someone who's had a C-section and no vaginal birth. New York State home birth guidelines say that it should be based on informed decision making. A person should be informed of the risk benefits of being at home, and a person should be informed of the risk benefits of having that primary VBAC in a hospital. Okay. It's a risk benefit analysis. Yeah. That's not considered the lowest risk category where we said it doesn't increase risks to baby and it's safer for the mother. That does not include a primary VBAC. But there's a risk benefit to it, and I don't want to imply, and that is
so it's not one answer. It really depends.
It's not one answer, exactly. It's more than a valid choice, and it's accessible, and there are many people walking around saying that they've only been able to pull off that VBAC because they did it at home. I've met a lot of people like that they had scenarios that had they been in a hospital setting, they would have had a repeat cesarean, but because they did it at home, they had that VBAC. But like I said, it's not risk-free to do it at home, and it may increase risk to a baby. So that's a very involved discussion beyond the scope of this conversation, but it's accessible in the state of New York, absolutely.
Okay, so that's a great answer. Thank you for that. Okay.
Sure.
I mean, we could go on and on. There's like tons of things to say, but I think we should wrap it up.
Okay.
Can you, hold on a second. Someone said in my stories, it took me 3 babies to do, and I'll never go back. It was a 5-star experience.
To have a home birth. Yeah. Once people have a home birth, by the way, I find that also the people who've tried both ways, they stick to home birth. And I want to say something else. And I'm thinking of professionals that I know, doulas and midwives. The people who have witnessed birth in both settings a number of times, have gone to a number of home births, have gone to a number of hospital births, they tend to choose home birth for their own child. And that's interesting to me. That's something to think about, that it's very much the people who mostly pontificate against home birth are usually the people who don't have experience with it. Professionals who don't have experience. And I think people should know that. If a physician tells them it's unsafe, the first question they should ask, have you been to 5 home births? That should be the first question, right?
Right. Totally.
Do you know what equipment the midwives come? Do you know? They could say, well, we know of a home birth transfer. Hospital-based providers only see the transfers. They don't see the thousands of peaceful births that unfold at home that don't need the hospital system, some of which would have been complicated had they been born in a hospital, would have had complications. So it's important to have a balanced perspective from professionals who've witnessed birth in both settings, and research that compares birth in both settings.
Right.
Like you said, that cultural bias,
Right.
Lauren, is very
Right.
important to address.
Right.
In the Netherlands, this would be a very different discussion.
Yeah.
In the Netherlands, you'd walk out of your house and a percentage of your block was born at home. It's
Right.
not like
Much more
she's
normalized.
a home birther. Do you know what I mean?
Yeah,
It's
and
much
I think
more
we need to
integrated.
question, like, you know, when we look at other countries that are having better outcomes than the US, because the US is not we are at the low end of the performance when it comes to maternity outcomes in terms of the developed world. I think we just need to question, is our system really the best one? Whereas if you look at a place like the Netherlands that has significantly better outcomes, they have a different balance of birth locations. It's not all home, but it's 20% home and 80% hospital. So maybe there's something to that. You know, maybe there is something to having more options and having this option, you know, more accessible for people. So just some food for thought for anyone listening. You know, I think it's really important to just have this like healthy level of skepticism and criticism on both sides, because that's really how you're going to get the answers. You know, if I'm going to ask you as a home birth midwife, well, how can this be safe for anyone? You know, then you can answer and I can say, okay. And then same thing with the hospital. You have to apply the same standard. So
totally.
Thank you so much for your valuable time. Is there any last piece of information or thought that you want to share before we close?
It's a good question. I would say what you said, Lauren. I love what you said. Gather information and make an informed choice so that you're setting yourself up for success and likelihood to have the birth experience you're looking to have. And that is different for every person. I really recommend the documentary, The Business of Being Born. I've met many people who have shown up to our home birth practice saying, I wish I knew about home birth earlier, or I was looking for this kind of experience, but I didn't know I could get it, or I didn't know insurance would cover it, or I didn't know that you would provide all the prenatal care and the lab work and you come to my labor and stay at my birth and stay postpartum and evaluate the newborn, and that the home birth midwives come back a day or two later and they do the 6-week postpartum visit. Like, there are people who just don't know about it. So I really recommend the documentary, The Business of Being Born. I think that's an eye-opening display of contrast of the maternity care system in either setting. I think it's great. That's a good
recommendation. And if people want to connect with you, how can they do that?
They can totally email us, office at Holistic Midwifery New York, spelled out, NEWYRK.com. Our phone number, I know that's so old-fashioned, 646 is 907-5515, the second extension. Or they can reach out on Instagram, and we have somebody who will monitor it. So they can totally reach out, Holistic Midwifery NY. That's where we're at. And we're a team of 3 midwives. So just so you know that. I don't want to, you know, I'm very grateful for my team. What could I say? I'm very grateful.
Great group there. Thank you so much for your time. This is a
Thank you, Lauren. You have such clarity. Thank you so much
for
this.
Thank you for joining. All right, take care.
Thank you. Bye-bye.